Next, I'm going to touch about the steps of respiratory system, which is firstly ventilation occurs. There are inhalation and exhalation. Next, secondly, at 1 and 2, as you can see from the picture, there are exchange gas occurs, which is oxygen are diffused from the alveoli to the blood, while carbon dioxide are diffused from the blood to the alveoli. And then the oxygenated blood is transported to the cells for the gas exchange. As you can see, at 3 and 4 there are gas exchange occurs, which is oxygen are diffused from the blood to the cells, and then the carbon dioxide are diffused from the cells to the blood. The carbon dioxide are produced because of the cellular utilizations, and then the oxygenated blood is transported back for the gas exchange. Next, respiratory tree. As you can see from the picture, it starts from the trachea and lead to the alveoli. For information, the human lung has 23 generations of branching airways. Next, alveoli structure. The wall of the alveoli are made of type 1 and type 2 cells. They are barrier for the gas exchange and it's really thin, which is separate at 0.2 micrometer. And alveoli provide a huge surface area for the gas exchange. Next is the mechanics of ventilation. There are two events occur, which is inspiration and expiration. Inspiration is when we inhale. There are two events occurs, which is contraction of diaphragm. In this case, the phrenic nerve activate the diaphragm, then the diaphragm contract, then the diaphragm move downward into the abdomen, then the thoracic cavity enlarge. Secondly, contraction of external intercostal muscles. The muscle contracts, the teeth move outward and outward, then the thoracic cavity expands. Next, the expiration. There are two events also occurs, which is firstly, relaxation of diaphragm. The diaphragm relaxes, so the diaphragm moves outward back into the thoracic cavity. Then the size of thorax will reduce. Secondly, relaxation of external intercostal muscles. First, the rib move downward and inward. Then the thoracic cavity's volume decrease. Now I'm going to talk about the physical properties of the lungs. First, they are compliance, which is how easy a lung can expand. Secondly, is elasticity, is the tendency to return to initial size after distension. Next, I'm going to talk about lung compliance. Lung compliance is how easily the lungs can expand when the pressure change. There are two factors of what affect the lung compliance, which is first is the elastic tissue. The more the elastic the tissue, the greater the lung compliance. Secondly, surface tension in alveoli. The higher surface tension than alveoli, it will reduce the lung compliance. Next, it is surface tension. Surface tension in the alveoli creates an inward force, the increased pressure. And the surface tension was caused by the film of fluid. The film of fluid is the formation of the attraction between H2O molecules by attractive force. And the surface tension can be described as the law of Laplace, as you can see. P equal to the 2 times T divided by R. P is the pressure of the alveoli, T is the surface tension, R is the radius of the alveoli. From the formula, from the law of Laplace, we can conclude that the pressure will increase with the surface tension increase, and the pressure increase as the radius of the alveoli R decrease. So to deal with this, surfactant is produced by the alveolar type 2 cells, as you can see from the picture. This surfactant will reduce the surface tension by breaking hydrogen bonds between water molecules.
So now we will go to the anatomy of respiratory system. If we look at here, respiratory system consists of inhaling and exhaling, which is inhaling is when you take in the oxygen, and exhaling is when you give off the carbon dioxide. It is made up of organs that involved in gases exchange, such as nose, pharynx, larynx, trachea, bronchi, and lungs. Respiratory system is very crucial for us to stay alive, so that we can inhale and exhale. So having a good respiratory system and a good health of lungs is very crucial for life. In here, in respiratory system, there is also respiratory tract, which is how the air from the outside environment when we inhale the air, how the air enters to our lung. So which are the tracks? So now we will go through that. First, it is divided into two, which is the upper respiratory tract, which is URT, and also lower respiratory tract, which is LRT. The URT, the components are nose, paranasal sinuses, pharynx, and larynx, where for the lower respiratory tract, the components are trachea, bronchi, bronchioles, lungs. The respiratory bronchioles, alveolar ducts, alveolar sacs, and alveoli, and also the last one is pleura. Then now we go to the components of the respiratory system. The first one is nose. Nose is the prominent structure between the eyes that serve as the entrance to the respiratory tract and contains the olfactory organ. The nose can be divided into external nose, nasal cavity, external nose, which is the portion for visible on face. So the external nose is basically this one, and the nasal cavity, which is inside the nose, the large cavity beyond nasal vestibule. So let us go through the external nose. The external nose is a pyramidal structure with its root located superiorly and apex sitting inferiorly. Attached to forehead by the root or bridge of the nose, spanning between the root and apex is the dorsum of the nose. The inferior to the apex are the two nares, which is nostrils, the openings to the nasal cavity. Each nostril is bounded laterally by the ala, which is lateral cartilaginous wings of the nose, and medially by the nasal septum. So that is for the nose. We move on to the nasal cavity. The nasal cavity is the internal part of the nose, which is inside the nose. It extends from the nasal vestibule externally to the cornea internally. So basically, the nasal vestibule is the beginning of nasal cavity. Small dilated chamber just inside nostrils, lined with stratified squamous epithelium. And also we have cornea. Cornea is what? Cornea is two openings or posterior nasal apertures, open into the nasopharynx, divided into right and left halves by the nasal septum. Each half has floor, roof, lateral wall, and medial wall. So that is for the nasal cavity. Now we will go to the next component, which is paranasal sinuses. The paranasal sinuses are cavities found in the interior of the maxilla, frontal, sphenoid, and ethmoid bones, situated around the nasal cavity and communicate through small apertures. They are lined with mucoperiosteum and filled with air. The sinuses consist of four paired cavities, each of which is named after the bone in which it is located. So, for example, the frontal sinuses, ethmoid sinuses, sphenoid sinuses, and maxillary sinuses. So it is simple. If you want to memorize the four paired cavities, just think that the name is actually based on their location. So the frontal sinuses, ethmoid, sphenoid, and maxillary. And now we will go through the pharynx. Pharynx is a throat. It is a muscular funnel-shaped tube extending about 13 cm from the cornea to the larynx. There are three regions of pharynx, which are nasopharynx, oropharynx, laryngopharynx. The nasopharynx passes only air and is lined by two main types of epithelium, which is respiratory epithelium and squamous epithelium. That is for nasopharynx. Next is oropharynx. Oropharynx and laryngopharynx pass air. They are same. Food. They are the same function, which is pass air, food, and drinks. Both are lined by stratified squamous epithelium. Then now we will go to the larynx. So after pharynx is larynx. Larynx is actually what? Larynx is the voice box. Larynx is the voice box. So if we see pharynx, pharynx is the throat, so the voice box is larynx. It is actually a short passageway that connects the laryngopharynx with the trachea. It lies in the middle of the neck, anterior to esophagus at the level of C4 to C6. The function of the larynx is what actually? It is actually to provide a pattern airway and actually to produce your sound, the voice production of yourself, and the roads for air and food into a proper it will route the air and food into a proper way. The wall of larynx is composed of 9 pieces of cartilage. 3 occurs singly, which is thyroid cartilage, epiglottis, cricoid cartilage. 3 occurs in pairs, which are arytenoid, cuneiform, and corniculate cartilage.
Hello guys, my name is Fu Jiaen, and now we will move on to the spirometer test. The spirometer test is using a spirometer, which is a device that helps us to measure the lung volume and capacity. Spirometer is a diagnostic device that measures the amount of air that a person can breathe in and out, and the time it takes a person to breathe out completely after they take a deep breath. So from this picture, this is an incentive spirometer which helps people to always keep their lung health after the surgery or any lung illness. So the people should always keep the ball at the center, not at the bottom or on top. So, other than the incentive spirometer, there are also several types of spirometer, for example, like the professional spirometer, digital peak flow spirometer, and digital smart spirometer. A professional spirometer is a more advanced device that provides a detailed analysis of lung function by measuring various parameters, for example, like forced expiratory volume and forced vital capacity. And it also helps to make accurate diagnosis and treatment plan to individual need. The digital peak flow spirometer and also the digital smart spirometer are designed to use in home. It is primarily used to measure the peak expiratory flow rate. Users can also quickly see how their lungs are performing and allow them to meet their medical advice if necessary. So the difference between the two devices is the digital smart spirometer has the Bluetooth setting, which can be linked to the device. There are 5 parts of dynamic lung volume. First is the forced vital capacity, FVC, time forced expiratory volume, peak expiratory flow rate, PEFR, minute ventilation, VE, alveolar ventilation, AV. So in my presentation, I will talking about the first 3. What is forced vital capacity? Forced vital capacity, FVC, is a maximum amount of air that a person can force exhale from lung after fully inspiration. The preferable is at least 6 seconds, and the amount of air is occupied 80% of total capacity of 4.8 liter. Next is the time forced expiratory volume, FEVT. In the FEVT, we are calculated by the time. So we got the FEV1. FEV1 is the volume of air that can first be blown out in 1 second after a full inspiration. So together with the FVC, we can predict whether a person is got any lung disease. In a healthy person, FEV1 over FVC should exceed 80%. So if a person got an obstructive disease, their FEV1 over FVC will less than the 80%. Normally it's around 45%. So for people who get the restrictive disease, FEV1 and FVC both reduce proportionally and cause the FEV1 over FVC to be normal or even increase. The next device is the spiral analyzer. Spiral analyzer is a medical device used to assess a patient's lung function. Okay, before this, I had introduced that many devices that can use to help us to measure the lung function. And among that, the digital peak flow spirometer and also the spiral analyzer, this tool is using by the measurement of the peak expiratory flow rate. So what is the peak expiratory flow rate? This PEFR is maximum flow rate in a single forced expiration. This measurement is believed in variable indicator of ventilation indicator as well as airflow obstruction. It helps to diagnose and to monitor progress of obstructive airway disease and also help to measure the degree of airway obstruction before and after bronchodilator administration in a patient. Okay, so do you guys know what is the difference between the obstructive disease and also the restrictive disease? The ulcerative disease is involved in the expiration, while the restrictive disease is involved in the inspiration. First is the ulcerative disease. Ulcerative disease is a condition that the people get it hard to exhale all the air inside the lung. For example, is a emphysema, chronic bronchitis, and asthma. While the restrictive disease is a people that have trouble fully expanding their lung with the air. The example diseases are interstitial fibrosis, muscular disease, chest wall deformities. So, we can predict a person whether he or she is in a healthy condition or having lung illness by using the spirometer. Because the spirometer will produce a graph that with the detailed data about a person. When a person is in when a person having the lung illness, for example, like obstructive lung disease and also the restrictive lung disease, their life graph will be lower than a normal person. It is because they are having a difficult in the inspiration or expiration. The same thing that apply with the restrictive lung disease. So from the spirometry test, a patient with restrictive lung disease normally will obtain a lower life graph. Same with the just now that the obstructive lung disease. So it is because that the patient cannot fully expand their lung with air. Normal person, their FEV1 over FVC should exceed 82%, but the people with this disease, they will have FEV1 over FVC less than 82%.
Hemoglobin saturation is the amount of oxygen bound by each molecule of hemoglobin. Each molecule can carry 4 oxygen. Oxygen bind to hemoglobin, form oxyhemoglobin, and oxygen not bound to hemoglobin referred as deoxyhemoglobin. Relationship between the percentage of saturation of Hb and PO2 is known as oxyhemoglobin dissociate curve. Affect oxyhemoglobin dissociate curve, which is temperature, HPH, PCO2, and 2,3-DPG in erythrocyte. High temperature will shift the curve to the right, but low temperature will shift the curve to the left. Temperature increase, so amount of oxygen released also increase. In pH, low pH will shift the curve to the right, shift the curve to the right, and low PCO2 shift the curve to the left. Hemoglobin release more oxygen as blood flow through active tissue that are producing more CO2. Muscular tissue during exercise. In 2,3-DPG. 2,3-DPG is diphosphoglycerate. It is produced by erythrocyte during anaerobic glycolysis and present in high concentration within red blood cells. Hemoglobin saturation at low PO2, which is low partial pressure of oxygen. PO2 refer to the percentage of hemoglobin molecule in blood that are bound oxygen when the oxygen concentration is low. At low PO2, hemoglobin affinity for oxygen decrease, meaning it releases 10% of CO2 will diffuse into bloodstream and dissolve in blood plasma to transport to the lung. And 30% of CO2 will diffuse into bloodstream and CO2 will bind with amino group hemoglobin to forming carbaminohemoglobin, and it will transport into the lung. 60% CO2 will diffuse into bloodstream. CO2 will react with water in red blood cell to forming carbonic acid. It will catalyze by enzyme carbonic anhydrase, so the reaction it will become fast. Carbonic acid, when water and carbon dioxide react, it will produce carbonic acid. And carbonic acid can dissolve into hydrogen ion and bicarbonate ion. Bicarbonate ion diffuse back into blood plasma. Red blood cell become positive charge. Chloride shift also can occur irreversible at lung, which is it will produce carbon dioxide. Chloride shift also.
Okay, so let's talk about how the respiratory system is regulated. So there are actually 3 types of regulations, which is regulation by the respiratory center, chemical regulation, and also the neural regulation. So I'll be talking about the respiratory center. So the respiratory center is actually part of your brainstem that controls respiration, mainly by the medulla oblongata and the pons. So the medulla oblongata actually has 2 centers or 2 groups, which is the DRG and VRG, also known as the dorsal and ventral respiratory groups, whereas the pontine centers, there are 2, which is the apneumotaxic center and the apneustic center. So the DRG is sometimes also known as the inspiratory area as it controls our inspiration. So the vagus and glossopharyngeal nerves will receive signals from peripheral chemoreceptors, baroreceptors, and other pulmonary receptors, and they will send these signals to the DRG to start the inspiration process. So the DRG will send signals to the external intercostal muscle via the intercostal nerve and also to the diaphragm via the phrenic nerve. So both of these muscles will contract, causing inspiration or inhalation. And after the inspiration, these muscles will relax on their own for a few seconds before the recoil of the lungs, which is the exhalation process. The VRG, however, or the ventral respiratory group, it is not involved in our regular breathing, but it is involved in our forceful respirations. So the DRG will actually stimulate the VRG, which will lead to the contraction of inspiratory and expiratory muscles. So during forceful inhalation, the VRG will cause the contraction of the sternocleidomastoids and the scalene muscles, which help in the forceful inhalation. Whereas during the forceful exhalation, the VRG will cause the contraction of the abdominal muscles and also the internal intercostal muscles, helping with the forceful exhalation. The apneustic center, it activates the inspiratory center or the DRG via the excitatory impulses. The apneustic center will cause the prolong of inspiration where the inhalation is deeper and longer. Whereas the pneumotaxic center, it actually inhibits the apneustic center. And because the apneustic center controls inspiration, therefore, when the apneustic center is inhibited, it actually inactivates the inspiratory center, causing shorter inhalations. And because our breathing in is shorter, so it actually also increases our breathing rate so that we can actually get adequate amount of oxygen. And that is all for the respiratory center.
Assalamualaikum. My name is Nadratul Fituna binti Bahrin, and I will present about regulation of respiration. The regulation of respiration consists of two processes, which are neural regulation and chemical regulation. So firstly, neural regulation of respiration. The neural regulation of respiration involves the interaction between respiratory centers, afferent nerves, which is sensory nerves, and efferent nerves, which is motor nerves. So firstly, the respiratory centers, which are located in the medulla oblongata and pons of the brainstem. These centers receive sensory information via afferent nerves about the level of oxygen and carbon dioxide in the blood. Based on this information, signals are sent via efferent nerves to respiratory muscles to adjust breathing. Then, the signals trigger the contraction and relaxation of respiratory muscles, leading to ventilation, which is the mechanical process of breathing. The ventilation ensures that oxygen enters the lungs and carbon dioxide is expelled. And then afferent pathway, which is respiratory centers, receive afferent impulses from various parts of the body based on the movements of the thoracic cage and lungs. The signals are sent from the peripheral chemoreceptors, which detect changes in oxygen, carbon dioxide, and pH levels. The signals also are sent from baroreceptors, which detect the blood pressure changes. The glossopharyngeal nerve and the vagus nerve carry the sensory impulses to the respiratory center. The last one that involved in this neural regulation is afferent nerves. So the afferent pathway is the nerve fibers from the respiratory centers located in the medulla and pons descend through the anterior part of the lateral column of the spinal cord. These nerve fibers terminate at motoneurons in the anterior horn cells of the cervical and thoracic segments of the spinal cord. These neurons give rise to two key sets of nerve fibers that control respiratory muscles, which are phrenic nerve fibers and intercostal nerve fibers. So the first one is phrenic nerve fibers, which is these nerve fibers supply the diaphragm, which is the primary muscle for breathing. The next one is intercostal nerve fibers, which supply the intercostal muscles, which assist in expanding and contracting the rib cage. Second process that involved in regulation of respiration is chemical regulation. This chemical regulation is operated through the chemoreceptors. The chemoreceptors is the receptors which give response to the changes in the chemical constituents of blood, such as hypoxia, hypercapnia, and increased hydrogen ions concentration. This chemical regulation involves two types of chemoreceptors, which are central chemoreceptors and peripheral chemoreceptors. This one is central chemoreceptors, which are sensory neurons located in the brainstem, specifically in the deeper part of the medulla oblongata near the dorsal group of neurons. They are part of a chemosensitive area responsible for detecting changes in the levels of carbon dioxide and hydrogen ions in the cerebrospinal fluid. So, hydrogen ions cannot cross the blood-brain barrier. However, carbon dioxide can diffuse freely across the blood-brain barrier because it is a gas. Inside the brain, carbon dioxide reacts with water to form carbonic acid, which quickly dissociates into hydrogen ions and bicarbonate ions. The increase in hydrogen ions directly stimulates the central chemoreceptors. This stimulation sends signals to the dorsal respiratory group, DRG, in the medulla oblongata, and then increasing the rate and depth of breathing to expel excess carbon dioxide. The peripheral chemoreceptors are located in carotid bodies, found at the branching of the common carotid arteries on either side of the neck, and aortic bodies that found in the arc of the aorta near the heart. These receptors are situated in the peripheral parts of the body, which is why they are called peripheral chemoreceptors. Peripheral chemoreceptors are primarily sensitive to low oxygen levels in the blood, specifically a reduction in the partial pressure of oxygen. While their primary function is to detect oxygen levels, they can also respond to a lesser extent to changes in carbon dioxide and pH. When the partial pressure of oxygen in arterial blood falls, the peripheral chemoreceptors become activated. The carotid bodies send signals via the glossopharyngeal nerve, while the aortic bodies send signals via the vagus nerve to the inspiratory center in the medulla oblongata of the brainstem. This will increase the rate and depth of breathing to restore oxygen levels.
Hello, doctor. Now I want to explain the table. So let me see what's the TB. The TB refer to the amount of air inhaled or exhaled during normal breathing. And what's the RIV? RIV refer to the maximum amount of the air that can be inhaled after a normal exhalation. And now it's the ERC. ERV refer to the maximum amount of air that can be exhaled after normal exhalation. Finally, it's RV. RV refer to the air that can remains in the lungs after maximum exhalation, which cannot be measured with a spirometer. So this is a table that I want to explain. Next is, so we can see the chart. The chart have axis and y-axis. The x-axis refer to represent time, while the y-axis show lung volume in milliliters, and the graphic illustrate breathing pattern and identify specific volume. So key points like TV, RIV, ERV, and RV are highlighted, and the yellow region denote calculative lung capacity such as total lung capacity TLC, showing the sum of all basic volume. So this is a table that I want to explain. So now I want to introduce some professional term like what's a TLC? TLC refers the total amount of air contained in the lungs after a maximum inhalation, and VC refer to maximum amount of air exhaled forcefully after maximum inhalation. So VC equal TV at IRV at ERV. So next is the FRC. FRC is the volume of air left in the lungs after normal exhalation. So FRC equal ERV at RV. Finally, is the IC. IC means the maximum volume of air that can be inhaled from the end of a normal exhalation. So IC equal TV at IRV. So this is the explanation of this chart. Now I want to talk about this chart. The chart illustrates it visualizes the relationship between time referred to axis, and the lung volume referred to y-axis, and it highlights the first point is basic lung volume, TV, IRV, ERV, RV as component of a lung function, and then it's the capacity TLC, VC, FRC, IC derived from the sys volume. So the graphical representation helps illustrate how breathing involves different capacity and volume for effective oxygen exchange. This slide explains the variation in lung volume and capacity. And the first is psychological factors, like lung capacity varies based on sex, higher in males, and second is age, incline with age, and body build taller equal larger capacity, and posture better in standing. Athletic training increases VC and race. And the second is pathological factors. Disease like this disease reduce lung capacity, and VC below 80% is considered abnormal. So this the slide made in plain. So this is meant about uh, the measurement. Spirometry is the most common test, measuring air volume and flow using a spirometer. So as we can see, this is the um, meaning of the spirometry and the measurement.
We'll talk about the transport of the respiratory gases. So in the atmosphere, there is nitrogen gas, oxygen gas, and also carbon dioxide gas. But in respiratory system, we only use the oxygen and also carbon dioxide. We will see how much the gas components will dissolve in plasma based on their solubility in water, not only the steep gradient. So we can see in the carbon dioxide, it is 20 times more soluble in water compared to oxygen. Although the steep gradient in partial pressure of carbon dioxide is low, but the solubility in water is high. Therefore, the amount of carbon dioxide and oxygen diffused. We talk about some laws that affect the partial pressure of the gases in our respiratory system. Dalton law stated that the pressure of each gas is independent of the pressure of the others in total of the gases in the air, while the Henry's law stated that the degree to which a gas dissolves in the liquid is proportional to both its partial pressure and its solubility in the. So now we will talk about the external respiration, which is also known as the pulmonary gas exchange. It says that it is the exchange of gases between the external environment and a distributing system of the body, or between the alveoli of the lungs and also the blood. The diffusion of oxygen and carbon dioxide is always in the opposite. Now we will see about the exchange of oxygen gas in our body. We can see that in the alveolus, the partial pressure of oxygen is 100 mmHg, which is very high, while the partial pressure of oxygen in pulmonary capillary is only 40 mmHg. Therefore, the oxygen will transported or diffused from alveolus to the pulmonary capillary, which is from the higher partial pressure to the lower partial pressure. When the oxygen diffused from alveolus to the pulmonary capillary, the partial pressure of oxygen will definitely increase. At the end of the blood flow, the partial pressure of oxygen will increase from 40 mmHg to 100 mmHg. And at the end of the capillary, we have the difference in the partial pressure of oxygen at the pulmonary vein and also pulmonary capillary. So it says that the partial pressure of oxygen at the pulmonary vein is less than the pulmonary capillary due to some of the portion of oxygen in the pulmonary vein will contribute to the respiratory system. After the exchange of oxygen gas, now we will move on to the carbon dioxide gas exchange. So in the alveolus, the partial pressure of carbon dioxide is low in volume, which is 40 mmHg, while the partial pressure of the carbon dioxide in the pulmonary capillary is slightly higher, which is 45 mmHg. So the partial difference of partial pressure of carbon dioxide in the pulmonary capillary and also alveolus allows it to reduce the pressure, which is from 45 mmHg to the 40 mmHg. And at the end of the blood flow, the partial pressure of carbon dioxide will become 40 mm. After that, we will talk about the internal respiration, which is also known as the systemic gas exchange. It says that it is the exchange of oxygen gas and carbon dioxide gas between the systemic capillaries and tissue cells. The diffusion of oxygen and carbon dioxide in this case is also the same, which is in the opposite direction. Next, we will talk about the exchange of oxygen gas in the internal respiration. So the oxygen that freshly transported from our lungs through the heart will be causes the partial pressure of oxygen high in the capillary, while in the tissue cells it has the partial pressure of oxygen is low, which is the 40 mmHg. This is due to the cells constantly use up the oxygen and convert it to ATP. After the oxygen diffused from the capillary into the tissue cells, it will decrease from the 95 mmHg to the final, which is the 40 mmHg. So moving on to the exchange of carbon dioxide gas tissue cells, we can see that in the tissue cells, the partial pressure of carbon dioxide is slightly higher than the partial pressure of carbon dioxide, which is higher than 5 mmHg. This is due to the waste we have produced during the cellular respiration. So the carbon dioxide will diffuse from the tissue cells to the capillary through higher partial pressure to the lower pressure of carbon dioxide. By the end of the blood flow, the partial pressure of all tissue cells will increase to carbon dioxide 45 mmHg. This is due to tissue cells. You see that the carbon dioxide also reveals the relationship between the carbon dioxide and also the alveolar ventilation. So we can see that in the x-axis we have the alveolar ventilation, while in the y-axis we have the alveolar partial pressure. So in this graph, we can see there's the volume of the partial pressure of the oxygen and also carbon dioxide. So the alveolar ventilation of oxygen will be increased with the alveolar partial pressure of oxygen in this graph, and the carbon dioxide is the vice versa. So for the normal resting values, oxygen is at the point of 100 mmHg, while the carbon dioxide normal resting values is at the 40 mmHg. If they is over or lesser than the amount, it is safe to having the hyperventilation, while when the value is too low, in between the range of 40 mmHg to 100 mmHg, it is safe to having the hypoventilation. Now I will explain about the hypoventilation and also the hyperventilation. Hypoventilation is the high in partial pressure of carbon dioxide, which is also known as the hypercapnia, and also indicate that it low in the partial pressure of oxygen. So the partial pressure of carbon dioxide indicate the low pH value, which has the high concentration of hydrogen ion, also known as the respiratory acidosis. Hence, we will increase in our rate and depth of the breathing. Now for the hyperventilation, it says to having the low in partial pressure of carbon dioxide, or also known as the hypocapnia, and it also indicate that it is high in the partial pressure of oxygen and also the high in pH value, which has the low hydrogen ion concentration, that known as respiratory alkalosis. Hence, we will decrease the rate and depth. Last but not least, we will talk about the oxygen composition in our blood. So less than 2% of oxygen will dissolve directly in our blood plasma, while more than 98% of the oxygen will bind with hemoglobin in red blood cell. So there is 0.3 per 100 milliliter dissolved oxygen found in our blood plasma. However, in the rest condition, we need at least 250 to 300 milliliter per minute oxygen. Therefore, there's about 20 over 100 milliliter dissolved oxygen will be found in hemoglobin. This is due to the 4 to 6 billion hemoglobins available in our blood. So the another way, which is the binding of hemoglobin with the oxygen. We can see that when the hemoglobin level is between low and normal, a person is said to be having anemia. While when the hemoglobin level is too high, it is said to having the polycythemia. So the hemoglobin production is controlled by the erythropoietin, which is stimulated by the partial pressure of carbon dioxide that delivery to kidney. So the loading and unloading of hemoglobin is based on two factors, which is partial pressure of oxygen in the environment and also the affinity between hemoglobin and oxygen.